This might be the most common complication after a knee replacement. It's one that probably worried me the most going into my own. It's so common, it's hard to call it a complication. And it's a leading cause of why some people end up dissatisfied after their knee replacement surgery. It's stiffness. There's a specific version of it with an intimidating name, arthrofibrosis. That just means scarring of the knee. We still understand surprisingly little about it, but that's changing, and some of the research coming out right now is genuinely exciting. I'll get to that at the end. I'm Dr. Randall Schultz. I'm a board-certified orthopedic surgeon who specializes in hip and knee replacement. I'm also a knee replacement patient myself, and I went into my own surgery worried about this exact problem. More on that a little later, because my story is relevant here. This is education, not medical advice. Your surgeon knows your knee and your situation. Always follow their specific guidance. To get into the knee, we have to cut through the capsular tissues around it. And no matter what fancy technique your surgeon may claim, the knee tissues begin to scar afterward. That's normal. That's healing. The difference is the rate. Everybody scars at a variable rate. People who scar at an extremely high rate are the ones who develop what we call arthrofibrosis, and it commonly leads to stiffness. The numbers bear this out. Depending on how you define it, somewhere between 1 and 6% of knee replacement patients develop clinically significant arthrofibrosis. That sounds low, but when you consider over 1 million knee replacements are done every year in the U.S. alone, we're talking about tens of thousands of people a year that are dealing with this. The standard treatment is manipulation under anesthesia in the early postoperative period. We put you to sleep and forcibly bend the knee to break up scar tissue. Sometimes we have to go further. Open the knee surgically or go in arthroscopically to remove scar tissue just to get the motion back. Especially if too much time has lapsed since the operation, the scar tissue becomes too strong to safely manipulate the knee. The data shows manipulation can help if done early, but it does carry real risk. A manipulation can cause a fracture. It can rupture the extensor mechanism. And there's a real downside. Every time we go back in and injure that knee, the body can start laying down fresh scar tissue again. You can end up right back where you started. But timing is critically important. There's good evidence that earlier manipulation within the first couple of months gives you a better shot at gaining motion than waiting. Patients manipulated earlier tend to get more flexion and score better on functional outcome measures. But even early, the results are variable. There's some encouraging long-term data. A large French multi-center study followed 344 patients who had a manipulation after knee replacement. They followed them out to about 5 years. On average, their motion improved by around 36 degrees, and that gain held at 5 years, ending to near 102 degrees. More than 3/4 of patients, about 78%, were satisfied with a low complication rate. So the gains can stick. The one important caveat, patients who needed a second manipulation gained far less, only about 17 degrees. So a manipulation can genuinely help, but it works best the first time, especially if done early. Who's at risk? We can predict some of this, not all of it. If you form keloids, those thick raised external scars, you may be more prone to arthrofibrosis. Both are the body overproducing collagen. Keloid formation is more common in people of African and Asian descent. If you're a keloid former, that's worth mentioning to your surgeon before your surgery. Also, have you had a problem like this with your other knee? That's a big one. A 2024 study looked at over 3,000 patients who had both knees replaced at different times. If you needed a manipulation after your first knee, you were nearly 14 times more likely to need one after the second. 14 times. That tells you that this is about your body's biology, not bad luck. Have you had prior surgery on this knee? Did you go in already stiff? The last one is huge. I'll come back to it with my own story. And then there's weight, obesity. A BMI over 30 is a recognized risk factor for both stiffness and for needing a manipulation. When we know the risk going in, the answer is vigilance. We increase the intensity of physical therapy, and we stress restoring motion as fast as possible. It's also why timing is so critical. I always talk about the ticking clock with regard to knee flexion or bending of the knee. The longer scar tissue has to form, the more rigid and leather-like it becomes, and the less you're ever able to stretch it back out. I'll give you another patented cheesy analogy of mine. Think of motion after knee replacement like trying to keep a driveway clear during a snowstorm. Now, not many of my fellow Texans are going to understand this much, but I did live in New England during training. But anyway, early after surgery, your body is in full healing mode. It's laying down scar tissue every day. That's the snowstorm. And in those first few weeks, for some people, it's not a light dusting, it's a blizzard. Physical therapy is you going outside with a shovel. Every day, sometimes multiple times a day. You have to clear the driveway so the path stays open. If the snow is falling faster than you're shoveling, the driveway starts to cover up with snow. That's stiffness. What makes it harder for some and not others, not everybody gets the same storm. Some people get a few inches of snow and can keep up pretty easily. Other people are dealing with heavy, wet snow coming down fast. Those are the patients who are more prone to arthrofibrosis. They aren't weaker, they aren't bad patients, they don't have a character flaw. Their body is just laying down scar tissue with more intensity. And let's be clear, there are some people, who just aren't willing to shovel snow. The good news is that the storm usually slows down. Early on, the scar tissue formation is most aggressive. Over time, it becomes less of a blizzard and more like occasional flurries. But the driveway you create in those early weeks often determines how open that path is going to be later. That's why the early motion matters so much. You're not just doing exercises for the sake of doing exercises. You're fighting to keep the path open while your body's trying to heal. When patients tell me they feel helpless against the diagnosis of arthrofibrosis, I push back. The condition's real. But it's not a wall you can't get over. It just means your path will take more effort and more resilience than someone with a different biology. You might need a snowplow, not just a shovel. I've had patients tell me, I just have arthrofibrosis. There's nothing I can do about it. I tell them there is something you can do. It's just going to be much harder for you than someone else. They look at me with a blank stare and say, I can't move it any more than this. It will not go back. But here's what I know. If we put that same patient to sleep, I can move it. It does go back. The motion is physically there. So a big part of this battle is mental, getting past the protective barrier your body has built. An arthrofibrosis diagnosis should never mean you can't regain your motion. In the vast majority of cases, you can. But you have to remember the clock is ticking and there isn't time to sit around and throw a pity party. If you're dealing with arthrofibrosis right now, don't give up. I'll be realistic. If it's been years and your knee only bends to 90 degrees, it's unlikely you'll gain a lot more. But that doesn't mean you can't try. And I've seen some people make small improvements even years down the road. I'd be careful about chasing surgical fixes. There are situations where the implant itself is part of the problem, placed incorrectly, oversized, or what we call malrotated, and those things can limit motion. It's also possible you have a loose implant or even an infection. Those things should always be evaluated and ruled out. But my personal opinion, if you can get through this without going back to the operating room, you're better off in the long run. I want to share my own story because it makes a point every patient should hear. Your range of motion going into surgery is the single best predictor of the motion you'll have afterward. Before my knee replacement, I'd already had 3 prior surgeries on that knee, including 1 open operation. Between that history and chronic arthritis, I was exceptionally stiff. I went into surgery with just under 100 degrees of flexion, and I genuinely worried, would I ever regain a functional range of motion, or would I be permanently limited in the things I love to do? It turned out better than I expected. Today, I comfortably clear 120 degrees or so. That, to me, is the sweet spot. But honestly, 90 degrees, a simple right angle, covers most of what daily life actually requires. So how much motion do you actually need? I don't love seeing people push beyond 130 degrees. I don't think our implants are well designed for that kind of motion, but that's more opinion than fact, and there's not a lot in daily life that really requires that much. Here's my view. Over 90 degrees, you can walk on almost any surface and get in and out of cars and normal seating. You'll still have some limits. Stairs, up and down, they can be a challenge. I personally live with a knee that only bent into the high 90s for a long time, and I knew those limitations intimately. But But given the risk of going back to chase a few more degrees, I typically advise against it. My rule of thumb, I want to see those patients easily clear 90 degrees by 6 weeks. If they haven't, that's when I start to consider manipulation. Ideally, I like to see 90 degrees within the first week or two, and in most cases, patients do get there. Focus on flexion today, bending the knee, because that's where arthrofibrosis tends to hit people hardest. Extension or straightening the knee is more of a muscle tightness or hamstring issue, plus how the implant fits rather than a capsular scarring problem. Since we're not creating much scar tissue reaction in the posterior capsule, arthrofibrosis doesn't affect that side as much, but it can. If you want more on range of motion milestones and why extension matters, I've got a whole episode on it. I'll link it below. I want to end on something hopeful because this is where it gets exciting. It's the next frontier for this surgery. We've known for a long time that the villain in arthrofibrosis is a protein called TGF-beta, transforming growth factor beta. It's the signal that tells your fibroblasts, the cells that make scar tissue, to ramp up collagen production. In arthrofibrosis, that signal is too loud. The body doesn't just heal, it overheals, and the excess scar tissue is what locks you up. So the question becomes, can we turn that signal down? That's exactly what researchers are working on right now, and there are several promising angles. The one I've watched most closely is losartan. You may know it as a common, inexpensive blood pressure medication. Millions of people take it, but it also happens to suppress TGF-beta signaling. The Steadman Philippon Research Institute, one of the premier sports medicine research centers in the world, is running a randomized placebo-controlled trial right now on whether giving losartan after a knee replacement can prevent arthrofibrosis. That trial is expected to finish in 2027. The early data is interesting but mixed. A large database study of over 1.3 million knee replacement patients found that people already taking losartan for their blood pressure were about 15% less likely to need a manipulation. Another analysis of over 100,000 patients found that this whole class of blood pressure drugs was associated with lower rates of manipulation, lower rates of surgery to remove scar tissue, and fewer implant complications. But a 2025 study out of Thomas Jefferson University looked specifically at this and didn't find a significant difference. So the picture is still coming into focus, which is exactly why that randomized trial is going to really matter. Beyond losartan, there's a newer approach I find fascinating. Researchers at Mayo Clinic are studying a compound called adipokine. In lab studies using actual human knee fibroblasts from knee replacement patients, including patients who already had arthrofibrosis, it reduced the TGF-beta-driven collagen production. They took it into rabbit knees and showed it could prevent contracture, and it was safe in these models. It's early lab and animal work, not human trials yet, but it attacks the problem through a completely different pathway than losartan. And a 2025 study went at it from yet another angle, getting cells to clean house, recycle their own damaged parts, which also turn down the collagen cascade. Again, bench science, not bedside, but it's another route to the same destination. Here's what all of this means to me as a clinician. Right now, our tools for arthrofibrosis are blunt. Manipulation, more surgery, more trauma to a knee that's already prone to scarring, and a lot of intense, often stern pep talks. But the future is hopefully going to be about prevention, a medication you might take after surgery that dials down your body's scarring response before it ever gets out of control. Maybe it's losartan, maybe it's something newer. But the science is moving, and I believe that within the next 5 to 10 years, we'll see a real shift in how we handle this. Hip replacement patients report overwhelming satisfaction. Knee replacement patient satisfaction lags a little bit behind it, around 80 to 90% in most modern studies. A big chunk of that dissatisfaction traces back to stiffness. If we can solve the scarring problem, we close that gap, and that's worth being excited about. So the key takeaways: stiffness is common. Arthrofibrosis is the high scarring extreme, but the motion is usually still there. The barrier is often as much mental as it is physical. Speed matters. Restore motion early, before scar tissue turns leather-like. Aim to clear 90 degrees early, within the first couple of weeks. Don't give up, and be cautious about chasing surgery to fix it, but always rule out a malposition, oversized implant, a loose implant, a knee infection, or any other primary problem with the knee joint itself. Keep an eye on the research. Preventing this problem, not just treating it, is closer than you think. I know a lot of you watching this are dealing with stiffness and arthrofibrosis right now. Some of you may feel like it made the whole knee replacement not worth it. The majority of people don't have this problem. If you're reading the comments while you're considering a knee replacement, please don't let this topic scare you away. Compare your knee to how it was before the operation, not to some perfect ideal. Even with some stiffness, I hope the majority of you find it's far better than the knee you had before. I know I have. Don't lose hope. I'll see you next time.